All right. Maybe, Salma, I'll ask you a quick one about where you think radiation and surgery may have opportunities to synergize in the same patient. Do you think there's still room to develop protocols where we do the sort of trimodality approach with and potential benefit to that?
Yeah, I mean, I think that, I think it's uncharted waters to some degree. We have seen some precedents with using neoadjuvant SBRT in some studies with immunotherapy and then operation. So potentially, and we've seen that both in like more intensive settings, such as the INCREASE trial, with sort of a more intensive chemo-RT approach versus just an SBRT approach. And obviously, there's really good results with some responses there. But I think it's like a learning space for everybody, right? To know how to do that safely, know how to best select patients. I mean, another approach is to think about this in the postoperative space, where we've sort of learned a little bit about postoperative radiation, and that there's probably some benefit in local control there. At least the signals would suggest so. But how to best select patients, how to really optimize that field design from the radiation standpoint. I think there's a lot left to learn, and we have to keep working at it.
Cool. John, can I just follow up on that question?
Yeah.
So the last part of your answer was about adjuvant, and I think we've learned from long art that post-surgery it's a bit difficult for some patients, but some of the patients that I personally struggle with is, when there's residual disease in the N2, and as surgeon, you know what it means to clear N2, and sometimes you wonder if what you really leave, if there's something that's left in place or not, and there's a lot of systemic options that are being developed right now to sort of answer that. But could you imagine a role of radiation in a patient that's persistent N2 disease on path?
Yeah, and I think that's a question that's being asked in in some of the cooperative group studies in the U.S. And yeah, I definitely think that's true, because again, we did see signals of improving local control in these historic post-op N2 studies, but they're again sort of these unselected populations and a variety of surgeries, a variety of pathologic understanding of the dissection, just a lot of kind of weaknesses in the study design that I think we don't really fully understand just reading the articles. So these are sort of unanswered questions we don't really know the answers to. But I think selecting those patients who have residual disease before the cat is out of the bag, so to speak, maybe trying to catch the disease while it's still in the mediastinum could make sense.
Okay, go ahead, please, Patrick.
No. Sorry. So one thing kind of that spans all three was the question of PD-L1, because the simplest marker we have is PD-L1, really. It's not ctDNA, it's not any of these other findings, and it's a continuous variable. So, for example, for your case, Matthew, if your PD-L1 was 90% and you had those findings, you could probably add up the variables and say this patient is 95% likely to have a PCR with nothing else, just with the imaging and the preoperative metrics. So I wonder for these studies like, so in terms of the induction study and omitting surgery or omitting radiation even, would we be preferred to focus on the PD-L1 high group initially, which is still 20% of patients or so?
Yeah, so for the SAFE trial, we thought about that, but because we wanted to recruit, we said we would be PD-L1 agnostic. John published a nice meta-analysis that, yes, PD-L1 above 50% do better, but regardless of the PD-L1, some patients achieve PCR. So to be more inclusive and to be able to enroll more, it's a PD-L1 agnostic trial, and currently in our center, we give PD-L1 agnostic chemo-IO. But definitely, and we all know that PD-L1I do better. But then can we discover those that have PD-L1 low and do well, or PD-L1I that do bad? That's also the next step. And also just to Dr. Baig was back, but and Dr. Rousseau, next time you have an N2 post-op, please refer your patient to Dr. Baig. She has a trial where patients are randomized to radiotherapy in post-operative N2. So important.
Thank you, Bertrand. Boris, did you have a question? Oh, sorry, is there someone else ahead of you?
Yeah, my question to Mathieu. Thank you for this presentation. regarding the surgical, the new surgical mindset, my question is like, when we talk to the patient, do you as a surgeon or we as a surgeon, like we have a different mindset, a new mindset regarding neoadjuvant disease? So you discuss with the patient the difficulty of the surgery before consenting them to this protocol. Is there any changes in your mindset as a surgeon while discussing with your patient throughout whole this procedure, this treatment that he's undergoing before consenting to this big major procedure, or you do it later on?
Yeah, so I think that's a good question, and I think there's a few answers to it. The first thing is, what the patient says, and I think this is true for any disease site. But when you offer neoadjuvant, often an answer from the patient is that they just want a tumor out, and they do push for upfront surgery, and so it takes the time to explain and make them understand that this plays in their favor. So that certainly has changed my approach a little bit, where I spend more time doing this. I do find that more and more that the detailed surgical discussion that I'll have will be post treatment, post scan, because it changes so much. I'll have a first initial discussion where I'll tell them what I think I'm going to do, and confirm that I think it's resectable and so on. But I do leave a big caveat there, and it could change. And going from thinking about a patient that we had recently that this was an open pneumonectomy for sure, and we ended up doing a VAT by sleeve, double sleeve lobectomy. This I could not have predicted from the beginning. So I think part of the discussion has also changed in terms of the timing of where it's being done.
Yeah, what I'd say is the importance of building a relationship. Having been a few places around the world, there are many places where the patient shows up in the surgeon's OR and it's their first encounter, which I find kind of psychotic. but that's happening in a lot of places, and I would say that the key is for the surgeons to build a relationship from the very beginning, and the discussion can evolve. Okay, one more question, then we're going to move on to our afternoon experiment.
Yeah,
Okay.
I just wanted to make a quick comment about these patients, considering that I just did a left pneumonectomy on a guy who had 15 to 17 centimeter tumor spanning left lower and upper lobes. There was absolutely no evidence of radiographic response post 3 cycles of chemoimmunotherapy. However, there was no viable tumor in the specimen. I do think that this is an area, these responses are rare, and I think that this is where a pooled analysis, but I think that if you have no ctDNA, if you have a complete radiographic response, I think that those are the patients that we should observe and not do hybrid things like, oh, I'm not going to operate now, so let's just secure it with radiation. And my second comment was about what you said about the frozen sections. And we have pathologists over here, and as challenging as it is to analyze MPR, PCR, and final specimen, and what we heard about pathologists, if you take all the pathologies around the world from major academic institutions through local areas, asking a general pathologist for a frozen section post-neoadjuvant chemoimmunotherapy, either on the parenchyma, bronchus, or vasculature, I'm not sure what the response would be. They would basically say, I don't know that I can help you make these decisions. And so I think that's what we struggle with, in terms of what is the reality and how can we standardize some of these approaches. But I agree with you that occasionally lesser resections could be performed, but we still need a final pathology from that.
Yeah.
Excellent. That's a great comment to close the session on. So thank you to the speakers. Thank you both, all 3 of you.